Welcome to the Moving Sides podcast program. Today, we are talking about the current and future role of MRI for diagnosis and prognosis of MS. My name is Olga Ciccarelli. I'm professor of neurology at the Institute of Neurology in Queen Square in London. And my co-chair is Massimo Filippi.
Hi, Olga. Thank you very much for the invitation and for this discussion. My name is Massimo Filippi. I'm full professor of neurology at Vita-Salute San Raffaele University, and I chair the neurological department here in San Raffaele.
Thank you, Massimo. I have a few questions for you. And the first question is about the current role of MRI in the clinical setting to make the diagnosis of MS. What do you think about that?
So, as you know, MRI has gained a major role in the study of MS. So, mainly in three main areas, which is diagnosis, as you mentioned, understanding disease pathophysiology, and monitoring treatment, which are now very meaningful for people with multiple sclerosis. The current use of MR is demonstration of two main aspects, which are critical for making a diagnosis. First of all, MRI is one of the instruments that we have available for excluding other conditions that might mimic MS. So this is a very relevant point because formal criteria then to demonstrate dissemination in space and time, which are the two pillars on which we base our diagnosis of MS, can only be done after having excluded other conditions. MS is a CNS inflammatory demyelinating condition that can affect any part of the CNS. So there are many mimickers of MS. Point one, to exclude other conditions is really central. And the second one is a demonstration of dissemination in space and time. So I guess these are the two main areas in which MR is presently used to diagnose MS, or to contribute with other clinical and laboratory testing to diagnose MS.
Thank you. And when you talk about dissemination in space and time, you mean about the presence of lesions?
Yes.
That can be shown on MRI as disseminated in different regions of the central nervous system and then occurring over time. And as you said, is MRI useful to distinguish MS for other diseases? But this is sometimes challenging. And why do you think it is often complicated to make the differential diagnosis using imaging? We have this very powerful tool, and despite that, it is challenging sometimes.
Yeah, you're right. Thank you. This is a very important question. It is challenging for a set of reasons. One I already mentioned, which is there are many possible mimickers of MS, some of which are more prevalent than MS. So we might see lesions in the brain which might resemble lesions of MS, but there are also other conditions that might give rise to a similar set of lesions, and they might be more frequent, so this might be a major issue. Point two is that, as you know, lesions in MS are seen because we have an increased water content within lesions, which can be caused by any aspects of the pathology of MS, from edema to axonal loss. And of course, this is very sensitive because of this, because it can catch any possible mechanism leading to formation of MS lesions. But on the other side, any condition that might increase water content might result in an increased signal intensity on MR, and this might be very challenging, I guess, mainly for these two reasons.
Yes, I agree. And it's very interesting that you said to think about the most common diseases first, the one with MS, instead of thinking of very rare conditions. We always have to keep in mind the prevalence of the disease in the area where we live and start with the most common diseases first, and then work down a list of differential diagnoses. And then this problem, the MRI is not pathologically specific, and therefore the signal abnormality can mean several things. So do you think in clinical practice, how do people use the MRI now? Should this change to reflect the recent guidelines from the McDonald criteria panel?
Yeah, I think so. I mean, with the McDonald criteria, we entered a sort of the contemporary era of diagnostic criteria for MS. So I think that the main merit of the McDonald criteria has introduced MR in a formal way in the demonstration of dissemination in space and time. We might remember early days when there was just clinical demonstration of dissemination in space and time, meaning on MRI we are looking for multiple lesions coming in different times. Clinically, we look for relapses involving different functional systems at different times. So this was the first classification, and we had a complex classification which was produced by Posa and co-workers. But I think that the main event in the diagnostic criteria was the McDonald criteria, first released in 2001, periodically revised. The last revision was in October 2023. We should have very soon the new criteria. I don't think we really need to enter into many details of these classifications. The point is that one that we already reminded, you can apply this criteria to show dissemination in space and time only when you have reasonably excluded other conditions. Otherwise, you overdiagnose MS. And point two, what we have seen over the years with the different revisions is to try to reduce the number of lesions that are needed to show dissemination in space and time. This, of course, has a price, which is a loss in specificity that we try to compensate through the point that I made already. So you have to be sure that other conditions are reasonably excluded. Because once you have done this, you want to be very sensitive because you wish to diagnose MS as early as possible, because this is not just an academic exercise. This is because we know that treatments are much more effective if they are started very soon in the course of the disease. By the way, already the disease has a biological evolution which is below the clinical threshold. So even when we start very early, we might be already late in the course of the disease. So we don't really need to miss additional time. So I guess the philosophy behind this criteria, then we might discuss the technicalities of the criteria, but the main point is to be very sensitive to make the diagnosis as early as possible. And in fact, I mean, Magnum's study, which is the European network on the use of MR in multiple sclerosis, has shown that with the criteria of 2017, which is the last version up to now, we reduced the time to diagnose MS in CIS people to 3 months on average, which was 13 with 2010 criteria, when it was 60 months with the clinical assessment.
Yes, so this is very important, how fast we can achieve the diagnosis of MS and how each revision of the McDonald criteria has simplified it in clinical practice. And you mentioned how MRI signal change, not specific for the pathology MS, and the new diagnostic criteria have tried to introduce more advanced imaging biomarker to increase the specificity. Do you think this is important for the future, how we use MRI for the diagnosis of MS?
Yeah, I do believe so, because I mean, the work that we have done up to now, up to the new criteria, which are not yet fully released, was the counting of lesions and the place where the lesions were located. So any lesions counted the same way. Now, I mean, in the new criteria, there is the introduction of lesions, for instance, lesions with the so-called central vein sign lesion. So meaning that you have an hyperintense rim around the hyperintense vessel, so which is very typical. Several studies shows this is very typical of MS. So typically, you have more than 50% of lesions in people with MS with the central vein sign. Typically, it's less than 50% in conditions that might mimic MS or enter in differential diagnosis. This is one example. The other example is the so-called paramagnetic rim lesions, which are under the umbrella of chronic active MS lesions, which are again something which seems to be more typical of MS than other mimickers. And so this, I think this is the main change, if I might say, in the new diagnostic criteria, which is the introduction of lesions that count per se independent of the location and the numbers, It counts that you have some lesions that are specific of these conditions. So what we are playing in terms of increasing sensitivity with this approach is somewhat safeguarded because we are introducing something which is more specific. So I do believe that this is a major step forward, and it will inform future application of MR in for diagnosis of MS.
Thank you. This is excellent. So we're all looking forward to reading this new paper on the recent revision of the McDonald criteria. So how we use MRI in clinical practice is also to formulate the prognosis of disability in MS. So what do you think are the MRI markers associated with disease progression that we can derive from MRI and how we use them?
I have a sort of personal view on this. I mean, when progression is there, I think that you have lost the game. So we should, sorry to be so straightforward and transparent, but our outcome should be to prevent initiation of progression. When progression is working, I mean, it is very difficult to change the fate of the disease. So, and work done especially in London by Olga and her group, and in Barcelona, Xavier Montalban in this group has shown that in people with clinically isolated syndromes, we are pretty well in making a reasonable prognosis in terms of accuracy, meaning that for people with, I mean, these are studies that are going on since 30 years or more in London, for instance, so MR has changed quite a lot, so we are still based on number and location of lesions, but it is pretty sure that if you have more than 10 lesions, for instance, in a clinically isolated syndrome, now at the time of diagnosis, the risk of having secondary progressive MS 20 or 30 years down the road is much higher. And we are pretty well in defining a prognosis on an individual patient basis based on number of lesions, location, so spinal cord and infratemporal located lesions, presence of simultaneous GAD-enhancing and non-enhancing lesions. So we are pretty accurate in defining a prognosis. So if we have several, I mean, without speaking of spinal cord that we didn't mention, which is relevant also for differential diagnosis, because lesions in the spinal cord are typical of MS, are much less frequent in mimicus, even in more prevalent mimicus, since we discussed this. I mean, in vascular conditions which are logarithmic times more than MS, I mean, it's very rare to find lesions in the spinal cord, which is not the case for MS, the same for vasculitis. So, but coming back to our point, we lose our ability to make a clear-cut prognosis like we do at the very beginning of the disease in the subsequent phase. So when disease duration is longer, and again, there is work to be done here to understand, I guess that we have some ideas such as gray matter, atrophy or damage in the brain and the spinal cord, presence of chronic active lesions that we mentioned already. But I mean, our power in defining subsequent prognosis is at least partially lost in the more advanced phases of the disease.
Yes, thank you. And you think that the innovations in MRI technology and AI be useful to diagnose MS and to predict outcome? You were discussing how sometimes it's difficult in individual patients to predict the outcome using one MRI only. So do you think that this could, for example, be an aspect that can be further enhanced by innovation, or do you see other technology advances?
I think that MRI has still a long life in front of her or his, I don't know. I think that you mentioned one major point, which is the use of artificial intelligence. So this might be very helpful in the diagnostic phase. So might be difficult for a human brain to put all the things together and to consider all the possibilities that the different crossing of data might mean. This is much easier for algorithm of artificial intelligence, as already shown by some groups, showing that there are some peculiar aspects that if the machine is trained, is able to be much more precise than people looking at MRI. Of course, then there is technical evolution of MR. I mean, We are in the field since a few years, Olga, right? And we saw something which we were not even imagining 10 years ago. So the field is really moving fast, and some of the aspects have already been suggested, such as lesions that are, for their qualitative characteristic, are suggestive of MS, and this can be done with the sequences that were not available 10 years or 5 years ago in such a precise way. And the other aspect that I think research should work, and I understand this is very difficult, but in which MR might be very relevant, is to try to do what our friends in Alzheimer's disease did, which is to define a biological diagnosis of the disease. Neurological conditions are characterized by the fact that there is a long biological phase preceding the clinical manifestation of the condition. And this is the case also for multiple sclerosis. So I think on something like showing the presence of waves of inflammation coming from outside to inside, together with the presence of neuroinflammation compartmentalized inside the central nervous system, might be a biological hallmark of the disease. So I'm just speculating, but showing presence of gut-enhancing lesions on the one side, or central vein sign lesions, which is a clear sign of something coming from the peripheries to the CNS, together with oligochronal bands, which is clearly a sign of immunopathology occurring inside the CNS, or the presence of paraguanetic rim lesions. We might be met a biological diagnosis of the disease, which sooner or later will be transformed into a clinical manifestation. And I really do believe that we need a cultural switch. Neurological conditions should be looked like the oncological conditions, which are, we don't wait too much. We are very aggressive because we understand that these are bad conditions. There should be the same public awareness for neurological conditions in general, and MS in particular. We can't wait. And point one, and we should take the risk of using treatment in order to modify the trajectory of the disease. We shouldn't be afraid of try to make the diagnosis as early as possible. Of course, we have to be accurate. We shouldn't mistreat people. So we are treating a very severe condition. So we should be ready to take some risk.
I like that. So we need to go back to the biological mechanism of the disease. And if we have indications from the biomarkers that this is MS, we should not wait for significant number of new symptoms or relapses to start treatment, but start early, because as you said, that this is the best way we have to prevent further disability or progression. So we discussed the diagnosis, we discussed the prognosis. My last question is about using MRI to monitor treatment efficacy and safety. What are your thoughts about that?
We are very used from clinical trials to use MR serially in order to monitor the efficacy and safety of experimental treatment. This should be, and it is the same also for already available treatment. I guess that at least at the beginning of the disease and at any treatment switch, we should perform an MRI. In the diagnostic phase, as the international guidelines suggest, I would use both brain and spinal cord MR and gadolinium enhancement. And then, as I was saying, for once the diagnosis has been established and treatment established, and or at any treatment switch, we might need to rebaseline the MR, and perhaps to follow up people with every 6 to 12 months, depending on the treatment used. Our aim is to so-called NIDA, so no evidence of disease activity. So lesions in MR might be present in people who are asymptomatic, and we wish that our treatment is suppressing any relapse on the one side and any new lesion on the other. But MR is also very useful also to detect possible side effects. Just remember what happened with PML in the past. The ability of MR to detect very soon any change that might suggest the presence of potentially lethal side effects has shown to be very relevant, because we can either on the one side make the assessment more frequent, and if something happens to stop immediately the treatment, and in this way protect our patients.
Thank you, Massimo. So I think we reached the end of our podcast. So thank you very much for your thoughtful answers.
Thank you for your questions.
Okay, so the future of MRI is bright. We are looking forward to further innovation to increase the specificity of MRI for MS and to improve our diagnosis of MS, to diagnose patients even earlier, and to be more accurate in predicting outcome and in formulate a correct prognosis.